Hi everybody, hope you're all having a great week. Our group decided to present on Guillain-Barré syndrome, and this is coming to you from Jessica Lago, Kristen Rowe, and Sarah Tapley. This is Kristen, so thanks for following along with me. Guillain-Barré syndrome, also known as GBS, is a rare but serious neurological disorder where your body's immune system mistakenly attacks the peripheral nerves. This leads to muscle weakness, sensory disturbances, and in severe cases, even paralysis. There is a treatment for GBS, but early recognition and starting the medical treatment early are essential to improving outcomes and preventing further complications. What is Guillain-Barré syndrome? GBS is an acute autoimmune disorder affecting the peripheral nervous system, which includes all the nerves outside the brain and the spinal cord. It often follows a bacterial infection and can progress rapidly over days to weeks. The exact cause is unknown, but it is believed to be triggered by your body's abnormal immune response to an infection. It's commonly associated with infections such as the C. jejuni, the Epstein-Barr virus, which leads to mono, the Zika virus, and the flu. In some severe cases, vaccines or recent surgeries may act as the trigger. Causes and risk factors. As I just went over, the most common trigger for GBS are those infections, and the C. jejuni specifically is the most strongly associated, but there are other viral and bacterial infections such as the flu, the Epstein-Barr, COVID-19 have all been linked. When you are getting GBS, the immune system is mistakenly targeting the peripheral nerves, and this is causing damage to the myelin sheath or the axons. And although it's rare, certain vaccinations and surgeries have been linked to GBS, potentially triggering the abnormal immune response. So the pathology. The pathology process involves several key steps, the first being the triggering event, which is the infection. The bacterium contains molecular structures that mimic components of human nerve cells. And this is going to be following specifically the C. jejuni infection. Next is the molecular mimicry and immune activation. So the gangliosides mimicry leads to the production of anti-ganglioside antibodies by the immune system. These antibodies are generated when antigen-presenting cells activate T cells, which in turn stimulate the B cells to differentiate into plasma cells and produce antibodies. This triggers an attack on the peripheral nerves. So the anti-ganglioside antibodies bind to gangliosides on the peripheral nerve axons, particularly at the nodes of Ranvier. The binding activates the complement system, forming a membrane attack complex. The complex disrupts the axonal membrane and increases calcium influx into the axon. This leads to axonal damage and perinodal detachment. The complement-mediated damage causes perinodal detachment where the myelin sheaths separate from the axons at the nodes of Ranvier. And the calcium influx that's happening contributes to further axonal injury, and this starts impairing the nerve conduction. Next is the macrophage involvement. They're recruited to the site of injury, and this even exacerbates axonal damage to the myelin and other cellular debris. And all of that leads to the neurological symptoms and the impaired nerve signaling, which causes your muscle weakness, paralysis, and sensory disturbances. The areas of the nervous system that are affected are the peripheral nerves, the autonomic nervous system, and the cranial nerves. So the peripheral nerves transmit sensory and motor signals between the brain and the rest of the body. Damage here results in weakness, numbness, and loss of reflexes. The autonomic nervous system, in some cases, GBS can affect this, and this can lead to fluctuations in blood pressure, abnormal heart rhythms, and even difficulties regulating body temperature. And cranial nerves can be involved, and this will lead to difficulties with facial movements, eye movements, abnormalities, difficulties swallowing, and slurred speech. So there are a couple different types of Guillain-Barré. There is the acute inflammatory demyelinating polyneuropathy. This is the most common form in North America and Europe. And it's characterized by immune-mediated damage to the myelin sheath, which leads to slower nerve signaling and the muscle weakness. There's Miller-Fisher syndrome. This is rare, and it primarily affects the coordination, the muscles that control eye movements, and the reflexes. Oftentimes, this is going to present with ataxia and you can read that word for yourself. Acute motor axonal neuropathy and acute motor sensory axonal neuropathy. This is most common in Asian and Latin America. These variants involve direct immune-mediated damage to the nerve axons rather than the damage to the myelin sheath, and this often leads to more severe and prolonged weakness. GBS currently affects approximately 1 to 2 people per 100,000 annually worldwide. It can occur at any age, but we see a higher prevalence in older adults and specifically males. And a history of a recent infection is present in more than 2/3 of all the cases. Although most individuals do have a full recovery, some can experience long-term complications such as persistent weakness, fatigue, and pain. And I know in my area of acute care, I've even seen where GBS patients, once they've had it one time, it's like they continue to have it. So they'll have it a second time and even a third time, and each time it seems to get a little bit more severe. The mortality rate ranges between 3 and 7%, and that's primarily due to complications like respiratory failure, pneumonia, or cardiac arrhythmias. In the United States, the annual incidence is 3,000 to 6,000 cases. It's more common in males, and older adults over the age of 50 have the highest risk. So age, gender, and ethnicity all seem to have a role. The higher incidence is in the older adults over 50 years old, more common in males, and some studies have suggested that a higher incidence is in Caucasians compared to other racial groups, but there does need to be more research on this. Signs and symptoms. So it's progressive muscle weakness that most of the time starts in the leg and starts spreading upwards. It feels like tingling, numbness, or pain that begins in the hands or the feet. Loss of reflexes, particularly in the knees and ankles. Difficulty walking, standing, or performing fine motor tasks. Respiratory issues if the diaphragm is affected. Can have fluctuations in blood pressure, heart rate abnormalities, and then in severe cases, you can have complete paralysis requiring ventilator support. For a diagnosis, the first step is a clinical exam. So it's going to be based on symptom progression, a neurological assessment, and if you have the history of the infection or a triggering event. They'll do a lumbar puncture to get some cerebrospinal fluid and see if you have an increase in white blood cells, because that's a characteristic of GBS. They might do an EMG or NCS to assess nerve function, and then blood tests and an MRI could be used to rule out other conditions that might mimic GBS, such as MS or transverse myelitis. There is treatment for Guillain-Barré. There's plasma exchange, which removes harmful antibodies from the bloodstream. There's the IVIG. This is the treatment that I see most commonly in the hospital. It's providing high doses of immunoglobulins to help modulate the immune response and prevent further nerve damage. So it almost kind of reverses the symptoms, and it's an IV infusion over the course of several days, and every dose that they get, it seems like, the damage is being a little bit more reversed. Supportive care includes monitoring breathing function, managing blood pressure, heart rate, and preventing DVTs and pneumonia, and then pain management for the pain that may be treated with medications such as gabapentin or opioids in severe cases. Movement of extremities done by caregivers to keep muscles flexible and strong. So we're going to be doing a lot of range of motion, and then a lot of interventions to support coping and fatigue, and strengthening, because most of these times individuals go from being perfectly fine 1 minute to they cannot walk, they're bedbound the next minute. So they're going to need a lot of coping, a lot of strengthening, and then training with adaptive equipment, such as wheelchairs or grab bars, bedside commodes, to support mobility and self-care. If it is left untreated, serious complications can occur. So this could be paralysis of breathing muscles, respiratory failure, cardiac arrest, or even death, but that is rare. But regardless, it is a very, very serious diagnosis, and you need to immediately seek medical attention. The majority of patients, 70 to 80%, recover fully within months to years. Around 20 to 30% of individuals experience lingering weakness or disability. Relapse occurs in 5% of cases, and early intervention with treatment significantly improves your outcomes. Severe cases with respiratory failure require prolonged intensive care and rehab. The recovery timeline and outcomes. So the progression phase, this is where symptoms are worsening. This is covering the first 2 weeks. The plateau phase, the condition stabilizes within 4 weeks, and the recovery phase is last, and it typically is between 6 to 12 months, but it can take up to 3 years to fully recover. But a couple of those statistics again, 80% will walk independently within 6 months, 60% regain full motor strength within 1 year, and only 5 to 10% experience delayed or incomplete recovery. So prognosis can be very, very good with treatment. And these are our references. Thank you guys for following along. Have a great day.